Vision loss is not just a clinical journey, it's an emotional one that affects the patient and their entire support system. In this episode, we explore how to lead with empathy, involve family members in care, and provide meaningful support through every stage of the geographic atrophy experience. Join me for this episode of the Defocus Media Podcast.
This is a Defocus Media production. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glovin.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus.
Hello, everybody. I'm Dr. Jennifer Lyerly, and I'm back on this episode of the Defocus Media Podcast with my friend, my classmate from optometry school, Dr. Sarah LeMay. It's so exciting to have you on the show as like a fellow classmate, Sarah.
Oh, it is exciting to see where we've come.
Yeah. So before the show, we were catching up a little bit about our life since Memphis, and Sarah recently won. I'm not going to brag about you because I know you're probably not going to do it yourself. She was recently recognized as Vision Monday's Rising Star. And so share a little bit about yourself and your practice, Sarah.
Sure. So I'm an optometrist at the Retina Associates of Kentucky, but I got introduced to optometry through my mom, who worked at the State Optometry Association. So you could say that I'm kind of like a child advocate and have always loved how much diversity our occupation can have, how we can go in different ways. And I love supporting other optometrists. Well, my husband, he is from upstate New York and has always dreamed about living in the Adirondacks. And I never wanted to stop him. So even though I thought I was always going to practice in my home state of Kentucky in a private practice, we ended up moving up north, and I found this OD-MD practice that I really enjoyed, and I found that I loved this model for optometry. While I was up there, I worked with retina, and I was really always challenged by the field of retina and wanted to know more about it. And I started listening to podcasts, kind of like yours, and I heard a podcast from Dr. John Kitchens, who's a mentor of mine and a partner at the practice I'm at right now. And they were talking about this novel treatment that was in clinical trials to treat geographic atrophy. And I was like, that just blew my mind. So I ran into him at a meeting, and he said that they were looking for a new optometrist. And lo and behold, here I am.
Well, that's incredible. I'm so happy for you that you kind of stumbled upon this path, because I know when we were graduating, we always were so focused on private practice. We were going to do full scope care, of course, in private practice, but not necessarily did you think that you were going to be such a retina focused doctor. And here you are, kind of like a leading retina optometrist. That's a very special place to be.
Always keep your mind open.
So on this episode, we're going to talk a lot about how the tough conversations that you're having to have with your patients. And I know when you are a retina specialist, we were talking about my tough conversations are with moms about their kid became a -1/4 myope, and that's devastating to them, like what we're going to do. Your tough conversations are around, oh my gosh, you are no longer legal to drive. Like the best vision we're getting is maybe legal blindness at this point. This is a whole different spectrum of discussion. And so how important are you finding it to be versed in these very difficult conversations and have the right language to help people through these hard times?
Yeah, I mean, I think it's really important to recognize that GA has an emotional and psychological toll on patients. And it can be just the same for that mom that's learning that their kid needs glasses. So it's honestly, it is the same level. It's all about us being able to understand that they have these concerns or these emotions, and us being able to detect those and calm them down with to give them a better understanding of the disease. I think the emotion that I run into most often with just a diagnosis of AMD in general is that the fact that the patient has fear. And it's mostly fear of the unknown, which again is the same as your parent that is concerned about their kid wearing glasses. So I do feel like it's my job to understand the disease and its progression and be able to convey this information to our patients, just to be able to take that fear away.
Yeah, when we think about macular degeneration, of course, there's a ton of fear that our patients have. They oftentimes have family members that they watched have significant vision loss with this disease. It's one of those conditions, much like glaucoma, that you say those words and you can immediately see the tension forming on someone's face. I often think about us as doctors and how we've had to rethink our understanding of, well, dry macular degeneration is mild and wet macular degeneration is the advanced form. And we know that's not the case. And geographic atrophy is advanced disease that causes severe vision loss. But patients, you're finding, have that misperception too. They're asking you, like, do I have the good kind or the bad kind? How do you approach that?
Yeah, I mean, it is our job to take down these misconceptions, because as soon as my referring provider tells a patient, you have macular degeneration, we need you to go to the retina specialist, they immediately start talking to their family and learn that so-and-so might have lost vision quickly, so-and-so lost all their vision, and they hear all sorts of stories. So it is our job to kind of take in their personal case and be able to break down these misnomers. And I think you're exactly right. I have patients all the time that ask me, well, what kind do I have? Do I have the good kind or the bad kind? And I then inform them, these are not mutually exclusive diseases. This is the same outcome. And depending on where you are, where a patient is, I kind of educate them based on that information.
How did you learn how to have these tough conversations? We really have to thread the needle when we're talking about geographic atrophy and macular degeneration and glaucoma, any of these conditions that cause vision loss. We don't want to create fear in our patients. They're already having a lot of fear and anxiety, but we also don't want to make it seem like it's not a big deal and then prevent them from taking the appropriate steps necessary to make sure that they're getting this condition treated. So was there any resources or anything that you found helpful to learn how to have these conversations, or did you just kind of learn it through experience?
Well, luckily I did just dive in head first and immerse myself in a clinic that these conversations, there's not a lot of ways I can avoid them. But luckily, due to these new novel treatments, if I feel like one of the best thing that's been gained from geographic atrophy treatment is the fact that we are looking into this disease with so much more care and understanding. So we now have the Geographic Atrophy Insight Study, which tells us that some different factors and they surveyed 203 adults across 9 countries, and they found that more than 70% of geographic atrophy patients rely on a caregiver. 46% of patients are anxious, and 39% even feel powerless. And these resources, we're now getting just such a better understanding, and we're able to use that to communicate to patients.
When you shared that study, it's really heartbreaking, because to ever underscore dry AMD as mild or not serious, like geographic atrophy is such a hard condition to live with. And the emotional toll, the toll that it takes on someone's lifestyle is really, really significant. And we know when we're seeing these patients for follow-up, when you have geographic atrophy, it does progress. And we're going to talk about treatments to try to slow that progression down. But you're facing a condition where that person is going to lose vision, and we have to do everything we can to save the vision that we can for them. But you're going to be on a very emotional journey with them. So how do you find that you're kind of staying empathetic, staying there for the patient throughout this process?
Yeah. So when I go for an exam, I am very regimented. I'm very much a checklist girl. So I have a certain pattern that I will approach every patient. And one of the superpowers that we have in retina that I completely acknowledge that a lot of my referring providers don't have are 2 things. The patient already knows that they have AMD, which that can be a very difficult conversation introducing the diagnosis of AMD. And then also what is amazing is that we already have imaging when they come in. So I'm already well-versed if they have wet or dry. I've looked at the OCT, I've ruled out fluid. I've looked at the wide field imaging. I get to see if their GA is foveal, subfoveal, or extrafoveal. And I use that information when I go in. And then my routine is that I want to listen to the patient's experience. They're very much human. This is their human experience. I want to listen to what they're noticing about their vision. And what's surprising with patients that have extrafoveal GA, which is 2/3 of patients that have GA have extrafoveal GA, meaning that it's not affecting their central vision. So a lot of these patients, they don't even know what to tell me. All they'll tell me is, well, something isn't right, or things aren't what they used to be. And it's my job, I feel, to really tell them at that stage that the things that they, if they're slowing down on their reading, or they feel like they can't see in a dark room anymore, as well, or if their contrast sensitivity is down, it's my job to tell them, no, this is not the normal aging process. This is due to your GA.
What kind of things are they going to experience in your experience, Dr. LeMay?
Yeah, so most people unanimously will tell me things just aren't what they used to be, but they'll start complaining about night driving. Mm-hmm. They'll start complaining about not being able to read as much as they used to because their reading rate goes down. So it might be a hobby that they enjoyed that they no longer get to divulge in quite as much. And then some people say, yeah, I just have to have a ton of light on everything to be able to see. And so you're really there to break down the fact that these aren't normal things. But when the GA gets into the center, it's very, very easy to explain to patients, yes, this is what's affecting your center of vision. This is how people have quantified vision, is how they perform on the Snellen chart. And it's very easy to explain what's happening.
I think this just underscores, when you have a person with the kind of GA we want to catch, extrafoveal,
yes.
maybe early stage, they're going to read just fine on the chart, potentially. They're going to have vague symptoms. And unless you're doing a very detailed macular assessment and probably utilizing things like autofluorescence imaging and OCT of the macula, you may not detect this. And that puts it on us to be really utilizing our retinal diagnostic tools to find these very sneaky small lesions so that we can start, a referral for treatment as soon as possible.
Right. I think imaging is such a good tool, and an OCT just to make sure that you're ruling out fluid, and then you're able to see early atrophy and advanced atrophy. I also use the ultra wide field imaging to show patients where their fovea is. So I actually like to point out, this is your fovea, this is your geographic atrophy. And if it's, outside of the fovea, I like to tell them if it grows into the fovea, then that's when your vision significantly reduces. And then a lot of times I can use the imaging to show them if there's growth. If over time I can see if it's grown towards the fovea or grown in size. So it's a really good tool.
Talking about growth of the geographic atrophy lesion, how quickly will a lesion typically grow in a year without any sort of interventional treatment?
Yeah. I get this question from patients all the time. They're like, how long do I have?
Yeah.
And the truth is we don't have a crystal ball with this job. We don't always know, but we can give them some averages. And the average time that after we identify and recognize GA, that it grows into the fovea is about 2.5 years. And also I like to show them this on size. This is where the wide field imaging becomes very useful. The median growth is about 1.7 millimeters squared per year. And that's approximately the size of the optic nerve. So I actually point to the optic nerve and I'm like, it will grow about this much over the next year.
That is horrifying to me.
Yeah.
Like think about, we're all envisioning our optos imaging right now, right? And thinking about the size of that nerve overlaid over an extrafoveal lesion, like, oh, that's in the macula. That's fast.
It might be like multi-lobulated and not all, growing together and towards the fovea, but that's about how much geographic atrophy grows. So it can have an impact on patients when they know sizing and areas where the atrophy is.
Now, one of the other real parts of what you do as their optometrist, obviously showing them why we care, talking about the symptoms they're going to have, but then also giving them some hope, right? So some tools, some resources. So what kind of things are you recommending to patients that whether they need it at that visit or you feel like they'll need it in the future, you want to make sure that they know these resources are available?
Right. So following kind of the hard information of what the disease is and how it's impacting their vision and what their future is, I do like to give them a little hope by telling them about resources. I like to introduce low vision early. I'm sure my low vision colleagues appreciate that, just so they can get used to using the tools. In my practice, we have a handout that actually will give them all the resources for low vision specialists, councils of the blind. It will give them contacts for audiobooks, large print books. It will show transportation services. So it's a really nice resource for the patients to fall back on if they're finding issues.
Well, and then the other thing that can give them hope is sharing about possible treatment for those patients that are candidates for it. What kind of conversations are you having around the injections for slowing geographic atrophy progression?
Yes. So this is not a short conversation.
Yeah.
So it's actually probably why they hired me in a way. So I could spend time while they're doing intravitreal injections.
Yeah.
So it's if you find that a patient is a good candidate for complement inhibitors, which the optimal candidate is a patient with extrafoveal GA, and you are trying to spare the fovea. I like to first and foremost inform the patients that unfortunately at this time, this treatment is not going to reverse any of the geographic atrophy in their eyes. It's not used to make their vision better. It is intended to slow down the growth of geographic atrophy and, specifically we're trying to spare that fovea. Unfortunately, it's not 100% effective. We have some, good data over how effective these these complement inhibitors have, and they're roughly about 20%. There's a lot of details with each one of the studies that got these FDA approved, but we wish it was 100%. But it is an option for patients to help slow it down and hopefully give them vision longer. And so that gives a lot of people some hope as well.
Yeah. You look at the GATHER studies with Izervay, maybe up to 35% slowdown rate. And I know we look at these numbers and we're like, oh my gosh, it's not 100%, right? The lesion does still grow. But then we think about, well, what's our other macular degeneration treatment that we recommend? The AREDS 2 vitamins. Mm-hmm. And think about the percentage slowdown on that. It's somewhere between 21 and 25%. And we all are recommending, we can get at least that much. And this is vision threatening disease. Any step you can take to slow that down might, be a life changer for that patient. Exactly. So I think we should feel empowered to talk about this as a positive to our patients, even though we know we can't stop the lesion from getting worse. Mm-hmm. Every little bit we slow it down gives them more runway to enjoy the vision that they have.
Sure. Definitely.
And so a lot of this, like you said, is falling on you as the optometrist here in this retinal clinic. Do you talk to patients about potential side effects, or is that something more the retina specialist is talking about before they do an injection?
Oh no, that's me too. So it is, it's a discussion. So all of our intravitreal injections, they do come along with risks. They are rare, but they exist. Most commonly endophthalmitis, and this is with any injection, endophthalmitis, vitreous hemorrhage, retinal detachment, again, very rare. But some additional risks that we want to make sure the patient's informed of with these complement inhibitors are one that really got a lot of attention is intraocular inflammation, retinal vasculitis, and worse off, vascular occlusive disease. During the FDA trials, both in the Gather 1 and 2, Oaks and Derby, there was no reports of retinal vasculitis or retinal occlusive disease. When pegcetacoplan came out on the market, there were starting to trickle in some reports of patients experiencing retinal vasculitis. So my group kind of took a little bit of a thoughtful pause on recommending complement inhibitors for a period of time. But then what we found through there was a committee, the ASRS committee, that gathered a lot of information over patients. And we found, after taking a thoughtful pause, that this happened after the first injection. So we kind of used that to our advantage, in that a lot of times if a patient has a worse seeing eye, we'll inject that one first and we won't inject both eyes at the same time. Just because we know that the likelihood of that happening on subsequent injections is rare. So if they don't have that rare reaction, then we can go ahead and inject both eyes, or the good eye as well. So it was something to navigate. It is something that a patient needs to know, that if they have any kind of vision loss or pain after any injection, that they need to alert us immediately. So,
and these are patients, I mean, just like any patient that's getting anti-VEGF treatments, like you're seeing them frequently. They're coming in for a monthly injection. This is a long-term commitment. So having a patient that is personally committed to seeing you every month, to having these follow-ups, to having that's such an important part of this whole process, right?
Yeah. And remember, the GAIN study found that 70% of these people rely on a caregiver. So that is also falling on their shoulders to transport these patients either every month or every other month to our office for these injections.
That is exactly what I wanted to talk to you next, because a lot of times this person needs a caregiver, and this person might come into their exam because we're talking about an elderly population, often with macular degeneration. And you're not just having to explain everything to the patient. You're having to explain everything to a spouse, a family member, a child, a caregiver, and have them enrolled and them bought in what's happening too. Do you have any advice on how to best bring the whole family and the whole team together on this?
Yes. I do love when the caregiver comes back with the patient so they can hear the whole conversation. I do feel like as providers, we need to be transparent on the vision prognosis and the effect that GA can have on their independence. For example, their driving capabilities, the ability to read medicine bottles, also read their own mail. I feel like they should know that these things might start to become a struggle. And then also empower the caregivers by letting them be informed of the resources that are available to the patient along the way as well. If the candidates if they are a candidate for complement inhibitors, then it's very much worth a discussion about transportation and the burden that they'll have to bring them in as well.
I just think it can be so overwhelming. And we've seen all these studies about when you talk to a patient, what small percentage of the information it's possible for them to take in.
Yep. Yes.
So whenever it's possible for them to have their family member or someone come into the exam room and we have HIPAA approval to have a discussion in front of everyone, my gosh, the more ears hearing, the better. I am completely on board with you with that.
Well, that's a great point. And I almost every time I sign someone up for complement inhibitors, I actually won't do it on the first exam. I will give them like a pamphlet about what pegcetacoplan is, what Avis and Captad-Pagol is, and then I let them go home and kind of digest it. So GA is not a very quick disease. It's a slow disease. So they have time to decide. So I always want them to come back. I want to show if there's any growth or not any growth. Of course, it's different if the GA is juxtafoveal, then I want to see them quicker. But if it's extrafoveal, pretty far away, I give them some time to decide. I tell them there's no exact rush. There is a time where it's going to be too late. But I do want that second exam just to be able to build more trust and be able to also give them time for questions and make sure that we understood each other.
That's fantastic. I want to take a moment here actually to shout out Izervay for making this podcast happen today. As you see, we're having a nuanced conversation about the disease. We're talking about both geographic atrophy products, but I just appreciate so much their support for making these conversations happen, for making sure that doctors are feeling versed and talking about geographic atrophy to their patients, recognizing the disease state, and also dealing with the emotional support that our patients are going to need. So thank you, Izervay, for making this conversation a possibility tonight. Let's talk a little bit about having this kind of hopeful tone still, because we're having hard conversations. We talked about the leading emotion you're facing is fear. How do we strike that balance to provide hope to our patients so that they're leaving still feeling empowered that there's something can be done?
Yeah, I think there's a couple key points that I have found that are important to mention during these GA exams. One, I feel like they have fear because they think they're going to lose all their vision.
Yeah.
So I like to remind them that this only affects their central vision, which is important, but their peripheral vision will not be threatened. So they'll always be able to navigate a room, see if someone's in the room with them. It's just they might not see their faces quite as clearly. And then I also like to remind them that it's not a fast disease. It's slow. They're not going to wake up and be completely blind in their eyes. It's a very slow process for majority of patients. I also like to remind them that as human beings, we're incredibly adaptive. And as the vision changes are slow, many times these patients are actually adapting and making modifications that they might not even know and realize that they're doing. They're already putting lights under cabinets in dark spaces. They're already using magnifiers next to their mail. They're already enlarging the print on their phones. So we're incredibly adaptive. And this one sounds strange, but it is so important to mention. For patients that have subfoveal central GA, they've had profound vision loss, if you ask them, a lot of them will probably report seeing images that are not there. And a lot of times patients won't be forthcoming about this. If you kind of have to really listen for it. And this is something called Charles Bonnet syndrome. Mm-hmm. And I think it's incredibly important to let them know that this is an outcome of their vision loss. They are not losing their minds, because a lot of patients are scared to mention it to doctors. And so I try to listen for some cues that they might be telling me. And then once you open up that Pandora's box, when you tell them that this is normal, they tell you all the very intricate images that they're seeing.
Oh, Sarah, now you have to share the craziest one you've heard now.
Small people.
Small people.
Small people it's probably one of my favorites. Flowers on the walls. There's all sorts of, they'll describe the most colorful images and they'll tell me they're beautiful. So I'm like, well, your mind is trying to fill you with beautiful images. So
that's great. Yeah, that's very nice.
Mm-hmm.
I think it's good, like you said, to get out in front of that. I will be the first to admit I've never thought to do that in my practice, to kind of let patients know up front, like, this might happen to you. I kind of have in my head thought like, oh, I would mention it if they start telling me they're seeing a bunch of stuff that I know is not there. But I think it's great to hear, like, no, yeah, get in front of it. That's advice I'm going to take back to patient care.
Yeah. I mean, you got to have a suspicion for it with the central GA.
Oh, yeah. Otherwise, it might be a little bit more concerning. I do want to point out, and agree with you, how many times I've reassured a patient that they aren't going to be blackout, no vision, no light perception, blind. And like, people think of macular degeneration. They know it's associated with vision loss, and they immediately think they will see nothing at all when I give them that diagnosis. And so reassuring them that will never happen, that we're talking about central vision loss, which is still devastating. I mean, think about all the things we need to do with central vision loss, but just knowing that you will be able to preserve your peripheral vision can give people a lot of hope. So yeah.
I've had some patients cry actually when I've told them that. And it's, they're just like, thank you so much. I had no idea. And it's it's an emotional experience for a lot of patients.
We as doctors know that, but our patients do not. And so we have to remember some of the things that they aren't going to be familiar with that we need to take that time to inform them about. So can you share some examples of how, you as their optometrist have kind of walked beside a patient through this process and kind of built that trust as they've moved forward through this disease condition?
Yeah, so I feel like patients respond really well when you approach them with warmth and competence. So I like to understand what emotions they're having about their diagnosis. And then I like to use my experience with the disease and my knowledge of the disease to kind of empower them and let them know that they're not alone. I think understanding their visual struggles at each visit, giving them resources is also a way to build trust. And then also just when you take that time to educate, give them resources, it's going to promote adherence to follow-up appointments, and it's going to build trust for better compliance.
I think this is the hardest one for doctors to hear, right? Because we both know time is what the patient needs. The patient needs to know that you're listening to them, that you're there for their questions. And it is very difficult in any practice, I know especially a retinal practice, to not have a schedule so full of patients that you really do feel a need to be like, here. But we have to make sure, even if there's a lot of people on the schedule, that we've made ways in our exam for the patient to feel like they are getting our full attention and all the time in the world. And so that's a hard balance for especially a lot of young doctors. I know I'm still working on it 15 years in.
Every day.
But that's the challenge for all of us in healthcare is how do we give utmost time with very little time?
Yes. Actually, participating in this podcast helped me kind of vamp what I was doing too. I was like, wow, I really need to start paying attention to these things again. So,
oh my goodness. Any advice for our fellow optometrists listening to this show about how to boost up their skills, how to best kind of enter patient care tomorrow, serving our patients that need our help with geographic atrophy?
Yes. Read the most up-to-date studies on treatment for GA. Really understand what the goals are, understand the disease and its different stages, and the impact that this can have on vision. Listen to your patients. We've said this so many times. Also, I advise you to know your local resources for the individuals that are suffering from impaired vision. Know when to share these with your patients. And then also refer at the right time to your retina specialist to consider GA treatment. And this does include talking to your retina specialist and figure out when they want to see them too.
Yeah. And every retina specialist I know might be a little bit different in the treatments they're offering and the care they're providing. So get to know your local doctors. You're going to be making referrals. You're going to be working together, and they're going to help answer those questions for you as the optometrist on what kind of discussion they want you to have with your patients. I know Daryl and I recently talked to our local retinal specialist that we both use about how he would like us to present this. How do we set it up for him to have the full discussion? And, everybody's going to be a little bit different on what they feel like you can best do to support what happens when they see the patient. So,
yes.
Sarah, it's been such a pleasure talking with you. Honestly, I can tell you have a lot of practice in having such a calm and warm presence. Not that this surprises me because I'm already your friend, but everyone listening to the show tonight is going to leave also being Sarah LeMay's friend. I feel like I have a very frenetic patient care energy after talking to you. I need to take a few deep breaths before I talk to people now.
Yes, don't have fear as well. So, but I feel like it's the more we know, the less fear we have also approaching these patients. So.
Well, if people are listening and they want to follow along with you and your retinal journey as an optometrist, where can they follow you and learn more?
Yes, so they can email me, LeMay at retinaky.com. Also, I participate in a podcast called the Doc to Doc podcast from Eye Care Professionals. So they can check me out on YouTube and Spotify with that. And hopefully I will be speaking at different state association meetings and national meetings in the future.
Well, I would love to go to your lecture. I'll be there in the front row. Okay. So it was so good to have you on the show, and just I can't wait to see you in person the next time we're able to get together. So thank you guys so much for tuning in and having this conversation with us about how to best support our patients that are dealing with the diagnosis of geographic atrophy. Until next time.
Hey, family, if you enjoyed this full podcast, don't miss out on more engaging content. Check out the next episode right here. And for the latest updates, hit that subscribe button and ring the notification bell. Your support means the world to us. Catch us in the next episode. Peace.